Alrighty. Good afternoon, everyone. Welcome to lecture. We're going to be talking today, chapter 5, about the patient. It's relatively short, so we may actually start a little bit of chapter 22 as well, the minimally invasive surgery. But let's go ahead and jump right into the patient. So, as kind of an introduction, every patient is different. And it's why we do what's called this patient-centered care. Everything that we do is with the patient in mind. Right? We're trying to, make sure that the patient is safe and comfortable, that we're doing, the correct procedures on them, all that, everything is with them in mind. We sterilize our instruments, the way we do our aseptic technique. Everything is thinking about that patient and trying to treat that patient as though they're a member of our family, so that we give them the best care possible. And we do it based on that particular individual as well, where, we're looking at their allergies and curtailing, our supplies and instrumentation and things like that we have on the field, based on, the patient's allergic to something or not, right? If the patient's allergic to betadine, then we're not using betadine as a prep. If the patient has a family history of malignant hyperthermia, then there's things we're doing to the anesthesia machine, flushing it out and changing out the soda lime and things like that to ensure that, nothing happens to that patient during surgery. But a lot of what we base, like patient needs and things is on this Maslow's hierarchy of needs. And anyone that's taken like a psychology class or like a sociology class or something like that, you've been introduced to this before. You've kind of seen this a little bit before. But basically what it is this pyramid. And the things that are most important to patients or to people, humans in general, are the things that are on the bottom. And then as you move up, they become a little less important to the individual. It's kind of how the Maslow's hierarchy of needs goes. Obviously, the bottom layer there, that physiological layer, that's all your like physical, how your body works, things like that. That's hunger, oxygen, things to keep you alive, right? And then as we move up, security and safety, this is feeling, having that kind of social and group of friends, feeling, safe and secure, like in a relationship or even in your job, kind of thing, and then it moves up, love, self-esteem, and then ultimately self-actualization, where we know ourselves. Like, you can sit back and reflect on a mistake you made or an accolade that you did and be able to break it down and dissect it and know for your own personal self where maybe improvement needs, and you're honest with yourself about these things. You're not, just like, oh yeah, I did that really, really well, when maybe you did it kind of mediocre or something like that. That's that self-actualization piece. Sorry, just putting down people as they arrive here, making sure I'm getting everybody their attendance. And the reason that's put in this triangle is for that, so that you need this base before you can move up. So before you can get to self-actualization, you're going to have to meet all of these other needs first. And then remember, these are basic human needs. So the Maslow's hierarchy of needs is off of basic human needs. Uh, like I said, you gotta fulfill those basic needs first before you can move to something else, right? If you're hungry or tired or sick or something like that, that physiological, then you're more concerned with getting that taken care of for yourself before you're thinking about like your own security and safety or love or your self-esteem. That's what you're most concerned with first. So you got to take care of that first. Um, and this being just this basic model for human needs, we also use it as this patient care because these are the things we know patients and people in general need. So if we can kind of take care of some of this, then it'll kind of fall into place for itself. The patient will feel more secure as long as, if we taking care of everything physiologically for them, we're feeding them when, dinner, breakfast, lunch, and dinner, even though hospital food's not the greatest food, right? We're making sure that they're secure and they're safe, right? We've got our side rails up. And when we're positioning them in surgery, we're making sure we're padding those bony prominences, things like that. We're not pinching nerves. Love, that's that kind of that therapeutic touch, right? When somebody's going to sleep, we're kind of holding their hand, that kind of feeds into that security and safety as well. But we're letting them know that we're there, we care. We're gonna do everything in our power not to let anything happen to them. Um, and then self-esteem, self-actualization, that's kind of like on the patient themselves. But as long as we're taking care of these, bottom parts of the triangle, the security and safety and the physiological, then now the patient can focus on these other areas for themselves. In the physiological domain, the things that kind of fit in there, right? Breathing, right? Oxygen, nutrition, eating or drinking, right? Transport, being able to move on their own, right? And that's why usually after like total joints or things like that, where a patient needs to get up and move, get moving, get walking around, we get them up as early as possible. We get them walking around the nursing units and walkers and things like that so that they can feel like, they have control of their own life, right? They're getting back to their version of normal, right? Excretion. This is, uh, defecating and urinating. Right? We can put a Foley in to help take care of that. Right? Each patient in their room should have, a bathroom. If a patient's not uh, ambulatory, they can't really get up and walk on their own. Then they hit the button and nurse comes in and helps them, get to the bathroom, that kind of thing. In the OR, we'll make that's another reason why we don't have them eat or drink anything, so that they don't have anything in their digestive system in case we're working on that area or something like that. We don't have to deal in a lot of fecal matter. There are times that we do have to because they have a blockage or something like that, but uh, for the most part, we're trying to stay away from that. Reproduction falls in there. How does that affect us in surgery? Well, we could be doing surgery that may affect their ability to reproduce. Right? We may be taking out a uterus or ovaries. We could be, doing a vasectomy or an orchiectomy. Right? We're removing one of the testicles or something like that. That's affecting that ability for reproduction. Right? Growth, repair, movement. All of these are physiological, or meaning physical things that our body does in kind of its function and its abilities to do things, right, to work. Safety and security, right? Most of the patients who come into the operating room are going to be afraid. Right? They're afraid of anesthesia, whether or not they're going to react to it. They're going to be nauseous, vomiting afterwards. Nobody likes. I shouldn't say nobody. There may be people out there that like to throw up, but most people, they just don't like that feeling of throwing up, right? So there's a fear there. There's a fear of death. right? Not waking up at all, being in excruciating pain, some kind of disfigurement. Right? Did we, they're going to have really bad scarring or something like that. They have no control of the situation. They have to basically turn all that control over to us in the room. They just get to lay there and say, okay, do what you do, and they have to kind of trust that nothing bad's going to happen to them, that we're going to take care of them like we said we would. Physical exposure. This is, you're wearing a hospital gown with nothing underneath and a blanket over the top of you. And when we move you over and we put you in these positions and things like that, things tend to get kind of shown sometimes. That could be another safety security type issue for the patient. Some patients, they don't care. You tell them to move from the gurney to the OR table, and they just take the blankets off and legs spray out, split all out, and they're like, whatever, you guys, the first time you guys have seen something like this or whatever, right? And they just don't care. Others are very shy about it, and they don't want anybody to see anything that they don't feel like they should be seeing. And that goes along with that loss of privacy. Once they go to sleep, they don't know what we do. Right? You hear stories of like dentists and surgeons and anesthesia and stuff like that of putting patients to sleep and then taking advantage of them or doing something to them while they're sleeping, and the patient has no idea. So that's a fear that kind of plays in the back of their head. It's something they think about getting wheeled in the room. We just have to do everything in our power to kind of put them at ease, let them know that they're in good hands. We're going to take real good care of them. To the best of our ability, nothing bad is going to happen. But at the same time, we can't really make promises either, because if something does happen, and now we're kind of held to that promise we made. So, your social kind of domain, right? This is that, belonging, right? Feeling accepted by a group, right? Feeling kind of the love, right? You guys are feeling this in class a little bit, right? You're starting to kind of bond with each other, telling stories about stuff that doesn't really necessarily have anything to do with ST. Right? You're telling life stories to each other. Everybody's kind of getting to know each other. You're fulfilling this need right now, this social type need. Now, sometimes the need is stronger in some than it is in others. Right? You'll have patients coming in, that may just want to talk your ear off, and others that they just stay real quiet and they don't want to engage in anything or anything like that. But with this belonging and the acceptance, let me see if I can't fix that. There we go. But this plays into the family of the patient, and being there and kind of, if let's say, for example, a female comes in, she wants to have her tubes tied. She wants to have what's called a tubal ligation, but her husband isn't in full agreement with it. But he's like, well, it's your body, you can do whatever you want to do, and you can kind of feel a little bit of the tension in pre-op when you go to pick up the patient or something like that. The husband's just kind of sitting there giving some nonverbal cues like arms crossed, not really engaging, not really talking to the wife or anything like that. Then what can happen is that after the patient has had surgery, her healing may take a little while longer, because now she's dealing with some stress because the husband's not fully behind her. Right? You can see the same thing sometimes in like cancer patients, who they started treatment, and the family's all there, full support, right? Because we're all in full support of a cancer patient. And then about halfway through, they decide they don't want to do the treatment anymore. They're done. You may lose, some of the family may start some kind of inner fighting that's going to put stress on that patient, because they don't want that kind of stuff happening with their family. They don't want to see them arguing and bickering over them. So I only bring that one up because that's actually a more personal story to me. My father last year was diagnosed with stage 4 cancer. It was lung cancer. He had a small node that started in his lung, and that spread to his brain. And the tumors they found in his brain were inoperable. But he could have done some radiation therapies, things like that, to lessen those. But he decided about halfway through that he was just done. It was taking too much of a toll on him, and he didn't want to do it anymore. That just so happened to not really cause any problems in our family, because we understand, hey, if that's what you want to do, then that's what you want to do. And we're fully behind you 100%. But it's still not it's not an easy thing to sit back and watch happen either. But you just got to keep reminding yourself that this is what they want. This isn't about what I want, or what his brother wants, or what his daughter wants, or his wife, or anything. It's what they want, and we just go with what the patient wants. But it's like self-esteem, self-image, right? What plays into here is kind of your own body image. Like, how do you see yourself? Right? I mean, is this your moneymaker? Right? And you're having some kind of surgery on your face, and now you're afraid it's going to leave some kind of scar or something like that. That's where that self-image comes in, because now you may think of yourself as less of a person. A lot of this body image, self-image, most of the time we're going to see it, and most concerned with it is like amputees, patients who are having mastectomies for like breast cancer. And we're not just talking about like doing like a little biopsy where you're just taking out a little piece of breast tissue. We're talking about you're taking an entire breast. So you can understand, like, breasts are one of those things that kind of make a female, right? It's one of those things that they use to kind of identify, right? And then if you take that away, now the patient starts to think to themselves, well, like, who am I now? Right? How do I identify now as a woman if I've lost my breast? Right? How are people going to perceive me? Right? How do they see me now? Are people, and you start to think, and kind of the tendency of human beings is to kind of think the worst, right? Like, I mean, have you ever walked into a room and there was a bunch of talking going on, and as soon as you walk in, all that talking stops? Right? Your first thought to yourself is, they were talking about me. When they very well could have not been. It just so happened when you walked in, you were right at the end of the conversation, and things just happened to stop. Right? But it's how we're perceiving it in our own mind that's going to affect us healing wise, because that's energy and stuff that's going towards thinking about that rather than going towards healing. Coping with any of these, with being sick or having surgery or anything like that, is completely unique to the individual. It's just like coping with any other situation. Right? If you've ever been in a relationship that you got your heart broken, some people go out and they go to the bar, or they go out to the clubs or whatever, and they hang out with their friends and they just party it up. Right? That's how they cope with that kind of heartbreak. Other people stay at home, cry it out, talk to, as many friends as they can, and get that reassurance that it wasn't them, it was the other person, right? That kind of thing. It's the same thing with, being sick and surgery, right? There's a kind of a stigma on men, right? When we get sick, we turn into babies. Right? We're like, oh, I'm sick. And, oh, can you bring me can you help me? And then females, sometimes they get sick, but they just keep pressing forward because they have that drive. They're like, there's too many things, that still need to be done. I can't afford to be in bed. Um, and then, but also you're going to have some females who turn into babies and just stay in bed, right? And you're going to have some males who have that drive and that push to getting better and doing better. An example of this is I worked with a nurse in Reno. He was an older gentleman, and he was going to have bilateral total knee replacements. So they were going to do both knees at the same time. Well, he, knowing these surgeries and having been part of these surgeries before in the past, and talking to these surgeons about what it takes for your recovery and things like that, he learned that if you strengthen your quad muscles prior to surgery, your recovery goes a lot easier. You get to walking sooner and things like that. So he spent the 2 months before his surgery getting his quad muscles in shape. And that's how he coped with his surgery, was he was trying to get better faster. Right? Everybody does it a little bit different. And some people it's based on like their culture or their belief and stuff like that. And that's where we as, healthcare professionals become a little culturally competent, right? We know a little bit about each kind of culture and things that we can do to kind of help put people at ease and work within, their cultural beliefs and things like that. So it's always it's individualized to that particular person, how that person wants to go about doing it. And then at the same token, not all patients are forward thinking like that either. Some are, they come in the room like, just do whatever you got to do. And they haven't thought about their recovery yet because they're still focused on the actual illness. So we talked about therapeutic touch before. There's also therapeutic communication, right? This is where we're talking to the patient about, their particular illness or the surgery they're going to be having. Have they thought about the things that are to come after surgery? Right? Because it's so easy to get focused on, oh, I'm having surgery, and you're going to telling like all your friends and your family and stuff like, oh, I'm going to be going to have, I'm going in to have surgery. They're going to be, taking this out or working on this or something like that, and you get lost in that, the actual process of that, and you don't think about what's to come after. So this is where we kind of come in, and mostly the nurses are the ones who are kind of, and it's the nurses on the floor mainly because they're the ones that have to give like education to these patients and teach them how to, take care of themselves when they get home and that kind of stuff. And this is, where we're, we go into it with a goal, right? As far as what we want to communicate to this patient, what we want to get across to them, what we want them to understand. And it's unique because it could be, like smoking cessation or, giving them a pneumonia vaccination. And you got to talk to them about, what are the good and bads of receiving that kind of thing, right? Or we're talking to them about their recovery or how to their, physical therapy following surgery, things like that. But you want to make sure that you're asking like open-ended questions, right? You don't want to ask questions that are going to get you a yes or no response. You want to be those open-ended so that you're getting that patient to engage. And you want them talking as much as possible, and then you're using your observation and your listening skills to what they're saying to you, and then curtailing, the further the conversation based on what they've said and their answers to some of your questions are and things like that. And then you can start to gear it more and make it even more individualized and unique to that patient. These are some common, techniques when using this therapeutic communication, right? It's that active listening. You're making eye contact with the person, right? You're not, over here doing something else and going, uh-huh, okay. And then they tell you that aliens came and landed in their backyard and have taken over their house, and you're just, oh, that's interesting. Yeah, I've never heard of something like that before, right? So you're not actively listening to what they're saying. So you, no other distractions. You're looking right at them, right? You're trying to provide them some kind of information, right? Whether that's educating them on how to use a walker or how to change out. Maybe they have to go home with a Foley, and showing them how to change out those Foleys and prevent infection and things like that. It's very focused on what you're going to be talking about, whatever it is for that particular patient, right? And then you want them, like, whenever they say something to you, or they're explaining, they're answering your question, you take what they said and you paraphrase it, you turn it into your own words, and then say it back to them. So now that gives you that clarifying piece. So now that's letting the sender know that you receive the message that they intended to send. And if it doesn't, like, you repeat it back to them and that's not what they meant to say, then they reword it into something else, and then you do it again. You paraphrase what they've said, re-say it back, and say, like, okay, so what you're saying is this, then, not this. And they're like, yes, and now we're on the same page, right? It also requires some kind of reflection, right? You thinking back to times that you've had this therapeutic communication with someone else, with another patient or a coworker or something like that, and thinking about what did and didn't work in that kind of situation, and then trying to change it up for the next time you talk to someone, just to making it better, right? If you realize that you typing stuff into a computer and looking at your computer screen and not at the patient didn't really work the last time, then maybe this time you don't do any of that and you actually pay attention. And then, of course, you're responding appropriately, and it just turns into a conversation where you're trying to get some information or provide some information. Spiritual needs. These could be, kind of a request of the patient, right? It doesn't necessarily mean any kind of particular religion. Right? Advent Health, I believe, is, I think it's Christian, I want to say. Maybe Catholic. But anyone of any, denomination, or even if you're not like religious like that, you're not part of a religious group, but you are spiritual, you believe in some kind of higher power and things like that, you can request that a chaplain come in and do like a little prayer with you or something like that before going back to surgery, things like that. It's here, like an example of this would be like a Jehovah's Witness. Is anyone Jehovah's Witness class? I don't know, 100%. I mean, it's not, something that I have to know or anything like that. But if, like Jehovah's Witnesses, I bring them up in particular, especially regarding medical, is they cannot receive blood transfusions. It's against their religion. They see it as it makes you like unclean, and you don't get admittance into heaven if you've done that. If you've taken someone else's blood into your body, they see that as no good. A lot of them will wear, they'll have like a bracelet on or something like that, telling them, letting uh, healthcare staff know that they're Jehovah's Witness in case they come in like unconscious. Some of them have like a card in their wallet, things like that. But it's something that we got to be aware of, just so that um, we're not accidentally doing that to that kind of patient. Um, but it's just being aware of it's maybe at that time because the patient's afraid, right? They need something to kind of hang on to, so they turn to kind of a spiritual side. Um, what else can I think of any other? I've had patients who uh, wanted like a quick prayer before they went to sleep in the operating room, right? And if you're not down with any of that, that's fine. You don't have to participate in it, but at the same token, be respectful and like don't like laugh or make a joke about it or anything like that, because that it's very important to the patient. And if they feel like they're comfortable and everything's feels comfortable for them, then they're gonna do much better recovery wise, because they're gonna feel right in all their basic needs being met, and then they can focus on themselves and just getting better. We do have some special type of patients. We're going to get to them in these slides, but they can bring up some challenges, right, in your ability to communicate with these patients, and especially their response to the surgery that's going to be happening. And you'll see when we talk about some of these guys. Uh, First off, we're going to be dealing with infants and children, because some of them need surgery too, right? And the way that we break these down is by these developmental stages, right? This is how they're developed, not just physically, but mentally as well, right? How are they able to understand things versus not, uh, that kind of stuff. Um, we do this separation chronologically, so by years or months in some cases, especially with the even youngers. But here's your breakdown, right? You got infants are newborn to 18 months are considered infant in the medical world. Right? Toddlers, 19 months to 3 years old. Right? Preschoolers, 4 to 6 years old. School age, 7 to 12. And then your adolescents, 13 to 16. Um, Sorry, I missed Ortiz. But yes, so we separate these chronologically, and then certain things, like if you're working on like these infants, there's certain things that we have to take into account on the field, because there's only a certain amount of local that we can inject into these patients, because medication is always the dosage of those medications is based on the patient's weight. So it's going to depend on how much that patient weighs on how much local they can actually receive. Um, and these aren't hard fast rules. If you've got an 18-month-old that is like 3 feet tall, weighs like 60, 70 pounds or something like that, then we will consider them more like a toddler, because they're big enough physically to be in this range, but mentally they're still back here in this infant stage. So we can kind of play around with the border areas here, depending on the actual size of the patient. But here's some of the considerations we take into account, um, with pediatric patients. these infants, they're going to have this separation anxiety from their parents, right? Or whoever happens to be, their caregiver. It could be a grandparent or an aunt or whatever it is. But usually when we go to take that patient to the operating room, that's when they're going to start screaming and crying and everything because we're taking them from their mom or dad, right? Toddlers, right? That's that 19-month to 3-year-old range. Uh, they can be very aggressive, get angry easily because they don't feel like they're being completely understood in what they want, right? They haven't fully learned how to speak, right? They know some words and some phrases. Some are a little more advanced than others, kind of thing. But they may not know how to exactly express themselves. So that leads to this frustration and anger, and that's the only way they know how to kind of like lash out and let you know, I don't like this or whatever. And they can even regress to kind of that infant stage and be afraid, that separation anxiety. And mommy, no, right? Preschoolers, they deal more on, uh, they feel like they're being abandoned or punished when being taken away from their mother or father to be taken back to surgery. Right? That could be an issue with them. Your school age kids, these are like your 6 to like 12-year-old or 7 to 12-year olds. They want to help. They want to do stuff, right? They see you put an IV in their arm, and so knowing this, you engage them, right? You put the little gauze on there, and when you're, if you're taking like an IV out and you're putting the dressing on, you can have them, hey, go ahead and hold this here for me, and they're oh, okay, and they're just interested in what you're doing, and then you put the tape over the top, and they're like, oh, or you put a nice little, if you got like if it's a little boy, you got like a little Batman or Superman Band-Aid that you're going to put on there, or even SpongeBob, and then you can have them help you put it on. And then adolescents, now we're talking body image, right? They're going through a lot of changes. 13 to 16-year-old, you're hitting that puberty, right? You get kind of shy about your body. You don't want people to see it, right? You got hair growing in places and things like that, and you may feel a little weird or whatever. So you don't want people seeing like your body. So you may be more prone to like keeping things closed up and things like that. We would just provide those patients with a little bit more assurance that we're not going to uncover anything that we don't need to. So on one end of the spectrum, you had pediatric patients. The other end, you've got the elderly patients. Right? Some things we need to take into account here. We've got some social considerations, their ability to move around, their mobility. Are they already in a walker? Are they wheelchair bound? Right? Do they get up and they're very active and they can move around no problem? Right? Do they have some previous surgeries maybe on their neck, or have they had other total joint replacements, things like that, right? What's their nutritional status? Have they been taking care of themselves? Have they been eating regularly? It tends to be that as you get older and stuff like that, you may not be hungry in the morning or at around lunchtime, and you just don't eat. But that's going to take a toll on the body. And then what's your cognitive impairment, right? How with it are you? Do you start to lose some of that cognitive impairment as the sun goes down? That does actually happen out there. I don't know if anyone has ever experienced that with a grandparent or ever worked at a retirement home or something like that. They have patients, they call them sundowners. When the sun starts to go down, they start to get confused. They lose some of that cognitive impairment. They have a maybe early onset dementia or something like that. And they become combative and kind of aggressive sometimes because they're confused. They don't know what's going on. They don't know, why am I here? Who are you? Why are you touching my stuff? That kind of thing. The other thing with the older patients is we have to be aware of how are they able to to do their ADLs. And an ADL means their activities of daily living. Can they dress themselves? Can they go to the bathroom themselves and be able to clean up, properly? Are they, can they brush their teeth? Can they shower on their own? All these kind of things. And it may lead into where, they need help at home or something like that. Some more here, right? What's the risk to this patient having surgery as it's related to another disease that they have? Right? Do they have diabetes? Right? That's going to be a big factor in your healing. It's going to take your wounds longer to heal if you have diabetes. Do you have congestive heart failure, emphysema, pneumonia? All any other kind of disease process you might be having going on. How is that going to affect that patient healing and post-op, things like that, right? Did we do something? Did we do a surgery that's going to affect their ability to like walk or move around, or did we do some kind of lung surgery where we removed one lung or part of one lung, right? Did we remove half of a liver? Did we remove some of their large intestine or small intestine? Things now you're losing that ability to absorb some nutrients and water and stuff. Was there a change in their cardiovascular function, their heart? Right? Is there an issue going on with their kidneys? Did they lose a kidney, or do they have renal failure? Right? A lot of the elderly patients have like frail skin. We need to do and take care of and make sure we protect, that skin. It could be just you barely rub your finger across it and you tear it, and that's a source of potential infection and a place for microbes to get in and things like that. That can give you another disease process going on, thus hindering your healing process again. Right? Do they have joint issues? Can they only lift their arm so high or out, bring it away from their body so far? Maybe we can't put that arm board out like as far out as we normally do. We have to keep it in because their shoulder doesn't move out like that, right? Do they have, muscular type problems where maybe they can't hold themselves up in bed, or they can't, get themselves over to the toilet to go to the bathroom? All those kind of things are going to come into play with the elderly patients. And again, it's going to be individualized to that particular patient, right? I'm sure all of you have heard or know of someone or who's like, 90 something years old, and they're out, driving race cars and, riding horses and doing all this stuff that like, a teenager or somebody in their 20s would be doing. But then there's also other 90 something year olds that, are bedridden and they don't go out and they don't do anything, and they're just kind of waiting for their time to be up. So, like I said, individualized to each of one of those patients. Right? Also, we can have patients who have sensory deficits, right? They could be hearing impaired, and blind, or even sight impaired, right? Not necessarily fully blind, but like partially, right? They could be malnourished, or, the sensory neural, meaning like you have a problem with like touch, right? You're not feeling when you're touching something, things like that. Right? And then we'll talk about each one of these. So like and then also you have like bariatric patients, right? Heavy patients, right? You got a lot of tissue, a lot of of them up and around the neck and area and stuff like that. When they lay flat, some of that can move up and kind of block your airway, make an obstruction, or you have a lot of extra tissue here in the neck and stuff. And when you lay flat, all of that's going to push down and can like narrow your airway a little bit. Now you're not bringing in as much oxygen, things like that. Your hemodynamic function, you have more of you, so there's a lot more vascularity. There's a lot more blood vessels that have to get to all those areas. So you're easier to bleed. Right? As far as your venous stasis means, this is the blood that's in your veins returning back to the heart so that it can get reoxygenated in the lungs and then go back out as arterial blood, right? Well, in the bariatric patients, the way that your blood moves back to the heart is just by you moving. It's your muscles contracting and pushing on those veins, and it squeezes that blood along. And then in your veins, you have little valves in the vein. So as the blood pushes, it opens the valve up and the blood pushes through, and then the valve closes back down so that blood can't go back where it came from. It's your muscles contracting that helps push that blood back along. Well, in some of your bariatric patients, there may not be a whole lot of movement around and things like that. There's a lot of sedentary kind of sitting around and stuff like that. You're going to get that pooling of blood in your veins. That's that venous stasis. Stasis meaning that things are just staying put. In this case, it's talking about the blood in the vessel. And any blood that pools or stays put for a long time makes clots. And those clots, when it makes the clot, it's called a thrombus, when it's just staying right where it's at. Then when it starts moving along in that venous system, it's now called an embolus. So now that clot, stationary is a thrombus. In movement, it's called an embolus. And if it gets to the heart or to the lungs, it can kill you instantly. Because it basically causes an air bubble in the system. You cannot have an air bubble in your vascular system. You will die. A lot of times these happen, this venous stasis, a lot of times it happens down in the calf. And that's where your clots will start, and then they'll move their way up and get to the heart or to the lungs, and then that's it. And then, obviously moving the patient requires, more people. There's going to be a lot more padding of areas, things like that. You don't want skin breakdown on these kind of patients because it's going to be very hard for them, to reach in areas that are broken down in the skin, because most often, you're talking around the coccyx area because there's a lot of sitting, right? And then, if you're resting like elbows on things, and if you're laying down a lot, the back of the head and the heels of the feet are your areas that press most often, and you're going to have skin breakdown in those spots. So it may be very difficult for that patient to keep like a dressing and to keep those areas clean, because one, they can't see them most often, and two, it'll be very hard for them to get to. They're going to have somebody else help them and take care of that. The category of bariatric comes from your BMI, or what's known as your body mass index. And the way that they figure this out is that they take your weight in kilograms and they divide it by your height in meters squared. And then that comes up with a number, and that's your body mass index. And then they compare that to the chart as to where you fall. Are you obese or morbidly obese? Or, if you're obese and morbidly obese, then you fall into that bariatric category. And then we have to, we use special instrumentation and stuff on the bariatric patients because we need things that are a little bit longer and stuff like that to kind of get down into areas. Your diabetic patient, right? This diabetes affects the vascular and the nervous system, and it's going to attack those that are the most peripheral first. So fingers and toes, and then also the vessels that are the smallest. So a lot of the vessels in the eyeballs themselves, those are usually where your smallest blood vessels live, is in the eyeball, which is why with diabetic patients, you're going to get what's called neuropathy, this nerve pain down in your feet and in your toes. And then you're also going to get blurred vision, because what happens is those blood vessels, those most peripheral blood vessels, uh, they start to die off because there's too much sugar in the bloodstream. And then it also, if you kill the vascularity to that area, now you're no longer bringing oxygen and nutrients to those tissues, and then the nerve starts to die. And that's where you get that nerve pain or neuropathies coming from. It's because the nerve is dying. It's sending signal to the brain, I'm hurting, I'm hurting, I'm hurting, but nothing's actually sticking or stabbing you. Also, like I said before, your wound healing takes longer when you're diabetic because you're affecting that vascularity. So you're not able to get all the nutrients and oxygen and like white blood cells and everything that you would have normally gotten there before you had diabetes. Now those structures are a little damaged and stuff, so you're not getting as much there as fast. If the patient is immunosuppressed, meaning like they have HIV or AIDS or something like that, or they have some other disease process that's going on that their immune system has had to kind of respond to, like COVID patients. This is why a lot of COVID patients were dying. And it wasn't just because of diabetes, but they had some other kind of disease process going on that had taxed their immune system and used up a lot of it. And now they got COVID, they went into the hospital and they ended up dying because, and they say they died from COVID. What would have been more accurate is to say that they died of complications of COVID, because what is it? I think like 1.5% of the world's population has actually died from COVID. Maybe even a little less than that, but and in the grand scheme of things, in terms of numbers, that's negligible. Like we've had more people die from the flu in the past than people who have died from COVID, but we never shut anything down for the flu. But that's how it can go. It can go, right? You're immunosuppressed. You have another disease process. Now you're having surgery, and it can kind of exacerbate things. Is what they say. Exacerbation means you're making things worse. And then, of course, with that prolonged wound healing, that's going to leave you at a greater risk for a hospital-acquired infection. Sorry. 2024? I don't know what that means. Hashtag 2024? Oh, were we talking about COVID? Is that when we're going to get rid of it? Oh, presidential run. My wife tells me that I cannot run for political office because she doesn't want to be in that limelight. So we'll put the nix on that. My brother, however, would be glad to run for president in 2024. Robert Logan, if anyone wants to write that in on the ballot. You probably don't want him as your president because he's very power hungry. And if you give him a little bit, I don't think he'll ever give it back. Just a personal note. Trauma patients, they're high risk because it depends on what's happened to them, right? Were they shot, stabbed? Were they in a car accident, right? Were they in some kind of industrial accident where something got crushed or ripped off or something like that? It's going to depend on what's going on exactly with that patient in terms of their risk in the operating room. Some patients can have yes, um, like developmental disabilities, right? Um, like Down syndrome or um, and when we're talking about like developmental abilities, we're not talking about like ADHD or dyslexia or any of that those and not to lessen those to any degree, but we're talking about more your cognitive ability, your ability to understand what's kind of being told to you, uh, your ability to understand the surgery itself and the risks and the benefits and things like that, right? You could have autistic patients and patients with cerebral palsy or some kind of other cognitive disorder like dementia or Alzheimer's, things like that. Is what we're talking about. And if a patient, um, just doesn't understand and they don't have the ability, they don't have that developmental ability to understand, then we're speaking with their caregiver. But it doesn't mean that we treat that patient as though they're not there. We still address them and talk to them and everything like that. But if we're going to maybe explain something or whatever, uh, knowing that they have a developmental disability, then we turn and kind of explain it to the caregiver, and then also try and involve that patient though still as much as possible, and so that they kind of get to see some things, maybe put some hands on some things, and kind of get a little bit of understanding of what's going to be happening with their care and their recovery. Um, Now, there's also a psychological component, right, to the patient. Right? Did they go through some kind of psychological uh, trauma in their past? Right? Were they abused? Um, were they emotionally abused or physically abused, or uh, do they did they have surgery before and things went bad? Right? They had a lot of infections and they had to come back from multiple surgeries, or somebody left something behind, right? Something like that. They've got a little bit of PTSD from it, right? And it can be triggered by certain little things, in the environment, especially if they've had surgery before and they had a really bad experience post-op. Now they're coming back for surgery again, and it doesn't have to be surgery on the same thing. It could be something else. The first time they came in, they had abdominal surgery. Now they're coming in and they're going to have a carpal tunnel. They're still going to have those same kind of feelings and think about things that happened before. You can be dealing with patients that come in with substance abuse issues. Um, the substance abuse, I've seen patients come in with something that's called compartment syndrome, where uh, the tissues surrounding like your muscles and things like that inside the fascia, those tissues start to swell for no reason really whatsoever. Usually, it has you had to have done some kind of event, maybe hit your arm or your leg up against something, and it caused kind of some deep tissue injury, and that tissue inside is swelling. But what's going to happen is it's going to start to put pressure on like your vessels and things like that, and because there's no break in the skin, it doesn't have anywhere to kind of swell to. So it's going to keep swelling inside until it either busts the skin open, and at that point it's going to kill all that tissue inside because you're blocking off that vascular, and you're not getting any oxygen and nutrients to those tissues. That cause for an immediate surgery where we go in and do a thing called a fasciotomy, where we're going to make incisions, like let's say it was in the lower leg, we're going to make incisions on either side of the lower leg to allow it to open and to swell. And we'll leave those open. We'll pack them with like wound vacs and things like that and send the patient to the ICU where they can continue to be monitored, but we're just releasing the skin. The only reason I bring that one up is because usually these patients with substance abuse, that's the surgery they're coming in to have done because they shot up with whatever, they smoked whatever, snorted whatever, and they fall asleep, they pass out, and they're laying on their arm or they're laying on their leg or something like that, and they're cutting the circulation off to that lower part. And most of you have probably done this at some point, right? You fell asleep laying on your arm, and then you wake up and you're like, and you can't really move it at first, right? And then the pins and needles come back, and you're like, and it kind of hurts. And that patient with the substance abuse, because of the whatever they took that made them pass out, they're not going to respond to their body telling them, "Hey, wake up! My hand is hurting," because it's asleep. They're going to stay passed out, and then when they finally do come to, it's been now too long, and you've gotten that internal swelling compartment syndrome going on, and you have to come to the hospital. I did deal with a patient like this once, and he was screaming at the surgeon, "You better not cut my leg off! You better not cut my leg off!" And finally, the surgeon had to yell back at him and tell him, "You need to just shut up and lay back and let us do our job. I'm not cutting your leg off. I'm here to take care of you. You need to calm down." And because of the substance abuse stuff, they're not in the right frame of mind. They're not thinking about, being rational or anything like that. So, the isolation patient, right? This is a patient that we've put on isolation precautions, whether it be airborne or contact or anything like that. And every time one of the hospital members come to you, they're dressed in all their full stuff, and their gloves and their gown and eye protection and mask and everything. And then now they're coming at you, and the patient starts to feel psychologically that nobody wants to touch me, nobody wants to get near me. We put them in special rooms with the airflow and all that kind of stuff so that we don't spread that throughout the hospital, right? But now they're in this room all by themselves pretty much all the time. And the only time they ever see somebody is they're all dressed up in their stuff, and they're being all careful to touch this and that, and they have follow all their special protocols. So the patients start to feel like they've got cooties, right? That nobody wants to touch me, nobody wants to be around me. Like your family can't really come and see you because you're on isolation and things like that. So you start to feel lonely and abandoned. The pregnant patient, early on, right? Pregnancy can be a good thing. People are, you get a lot of attention. Oh, look, you're glowing. Oh, when are you due? Blah, 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 that kind of thing. But as the pregnancy starts to progress, right, your ankles start to swell, retaining fluid, the baby's constantly moving around, putting pressure on your bladder. You feel like you got to pee every 5 seconds, right? You can't fully lay on your back, right? You always have to be cocked up to one side. You can never really get comfortable when going to bed, right? And all that starts to eat at you upstairs, right? And that's why pregnant women can be snappy at people and quick to yell at somebody, or and people just go, "Oh well, she's just pregnant," or whatever, and instead of actually going through with maybe some therapeutic communication, right? Talking to that person, finding out what it is that's really irritating them, and seeing if you can't do something to maybe help rectify that. That's kind of a man thing, right? People come to us with a problem. Our thought is, "Hey, here's a solution." May not always work with the pregnant patient, right? Maybe they don't want you to solve the problem. They just want you to listen to it and agree with them and be like, "Oh yeah, that's not right," or "Oh, that's messed up," or but you don't want to try and offer up something as a solution because you might get your head chopped off. Actually, I don't want to hit questions yet. I want to go back to these. So, with your hearing and sight impaired patients. So with the hearing impaired, they may have hearing aids in. We let them keep those hearing aids all the way up until the point they go to sleep. so that they can hear what's going on and that they feel still included. Because as soon as you take those away, now they can't hear anything. With deaf patients, we try to not, if we have somebody who can do sign language, we try to do that. But most often, what you'll see initially out there is people will raise their voice to them. If anyone has ever dealt with like a deaf person or whatever, you know that yelling at them does nothing. It's not going to make them hear you any better, but something in our brains just kind of immediately goes to that. Oh, you can't hear me? Then let me yell at you. Maybe you'll hear me now. Most of what we want to do with deaf patients who can't hear at all, is use a lot of visual cues, right? Like if you want them to move from the gurney to the bed, you like kind of tap the bed and then motion for them to move over, right? And then with your blind patients, this is where you need to be able to use your verbal a lot more and let them use their touch, right? If they're on the gurney and you want them to move over to the OR bed, you tell them, hey, just to your right side, there's a new bed there. If you reach out, you can feel it. And then they reach out and they kind of feel it. I'm going to need you to stay on your back and using your hips and your shoulders, slide on over to this new bed. And I'm over here on this side. Just come to my voice, right? You get them, and you have to use a lot more verbal cues and explain a lot more with the blind patient. Okay. Any questions on any of that? Those are kind of some of the special patients we'll see in the operating room and that we'll take care of. Chapter 22 now. What? It's not chapter 22. That's chapter 20. So this is minimally invasive, endoscopic, and robotic surgery. Minimally invasive just means that we're going through small incisions. We're using some kind of port or trocar, something like that, to feed instrumentation through to get us to the area we need to work. We'll start off with endoscopy first. So endoscopy is their own separate department in the hospital. This is where we do like what's called EGDs, or esophageal, gastro, duodenal scoping, or visualization, where we're going to take a scope and put it down your throat and look down at your esophagus and go into your stomach and then down into the duodenum, which is the first part of your small intestine off the stomach. We can also do colonoscopies, come from the other way and look at all of the colon, looking for like cancer, things like that. So that you can either do them diagnostically. Diagnostic means we're just looking. We don't do anything else. We're just looking. So this is, you put the scope in and then you see, oh, it looks like you may have like a little polyp here, but all you're doing is seeing it and recording what you saw. Operative endoscopy now means you're still going in with that same scope and you're going to see that same little polyp, but now you're going to put an instrument down that scope and take maybe a little piece of it, a biopsy of it. Those are operative endoscopies. Diagnostic is you're just looking to see what's there and then reporting on it and then coming up with a plan afterwards on how to deal with what you found. Operative is you see something there and you do something about it in that moment. This is going to become important to you guys, especially endoscopy. in clinicals, because you will spend at least a week in an endoscopy department, and your second scrub general surgery cases, you need 10 of them. Any endoscopy case that you do that's operative, that like takes a biopsy or remove something, whatever, those are considered second scrub general surgery cases. So you will get all 10 of your second scrub general surgery cases in the endoscopy department. Oh, no. So some of the basic kind of concepts of minimally invasive surgery is that you're viewing with a scope, some kind of telescopic viewing. You need the actual scope itself to be able to see inside of the body. Okay? You're going to put in some kind of cannula or trocar. What this means is that it's hollow down the middle of it. And we'll insert that into the body, wherever, outside of whatever cavity or area that we're going to be accessing. And now we can put instruments through that cannula, and then with the scope, now be able to see the ends of those instruments and all the anatomy inside and what we're working on, what we're grabbing, that kind of thing. We have to provide protection for the body wall. Right? The cannula helps kind of do that with the in and out of the instruments, but we also do that through like an insufflation or a distension of an area. The difference between insufflation and the distension is that insufflation is done with a gas. Distension is done with a fluid. So the places we'll be using the gas is like the abdominal cavity. We inflate or insufflate the inside of the cavity with CO2 gas, and it makes the abdomen puff up like a balloon like this. That gives us our exposure. It moves the body wall away from all of the internal organs and everything that we're going to be working on, and gives us that space to kind of grab things and pick things up and move things around and work it. In a joint, because our joints typically have what's called synovial fluid in them, right, for ease of movement. That's where we use fluid, because we have to replace a fluid that's already in there. So that's distension, is when we're using fluid to kind of build up a joint space so that we can put instrumentation in there and work around. And that's going to allow us, so this protection of the body wall and this protective seal and the manipulation of these instruments, this is all done by either distension or insufflation. And the cannula is going to help maintain this seal so that we can go in and out with instrumentation and not either have that fluid completely pouring out or the gas just leaking out. But we do minimally invasive surgeries across many different specialties, right? Ortho, neuro, urology, vascular, general surgery. Hearts does some things using the minimally invasive techniques, but the principles are the same. Right? You have to have some kind of scope like this. Right? You need a cannula to put that scope in, to leave the portal or the incision you make open, so you can go in and out with instrumentation. You don't have to go in through that little incision and kind of find your way every time you want to put something in. Right? You need some kind of imaging system. Right? You need a monitor. You need somewhere to plug the camera into, somewhere to plug your light source and everything, so that you can get a picture on your screen, on your little TV screen, so you can actually see what you're doing, right? And there's that insufflation versus irrigation, right? Insufflation or distension, right? Depending on where you're working. Right? And this balloon expansion, this is particularly for inguinal hernias. If you're going to be repairing them, the laparoscopic approach, you're going to put in a special balloon that helps separate all those tissues in the inguinal area from inside the body, so that when you get in, it's already all kind of dissected for you, and you just have to kind of clean up a little bit and then place the mesh and be done. Some advantages of minimally invasive surgery, right? You can do a lot of different things this way. You're lessening the tissue damage or trauma that you're creating, right? You're making an incision about an inch long versus an incision that's like 7 or 8 inches long to do an exploratory laparotomy, open somebody completely up. Less blood loss, right? Smaller incision, less bleeding, faster recovery for these patients, right? Now, a lot of things that you'd have to stay overnight for in the hospital after your surgery was done can now be done on an outpatient basis. You can go home the same day that you had your surgery, right? Less money in insurance cost, things like that. Right? Decreased pain, smaller incision versus big old long incision. Right? We didn't have to cut you as much, right? Now all of these things will increase our patients' satisfactions, and it's also less costly. Your hospital stay is shortened. Insurance doesn't have to dole out so much money. Your insurance premiums can stay low because they don't have to spend so much money out for procedures and things like that. And you can get a lot more done and be up and back to your normal faster. Now, some disadvantage or limitations of minimally invasive surgery is that there's a big learning curve to it. Right? If you play a lot of video games and things like that, that's why these new generation of surgeons that are coming out are extremely proficient at these kind of surgeries, because that's how they grew up. Right? There's a lot of this minimally invasive type stuff, or there's this, video game systems. They're very versed in, like computers and monitors and, how these things kind of like interact with one another and stuff like that. As opposed to the old school surgeons, like when I first started, laparoscopic surgery was still kind of in its infancy. So you didn't have a whole lot of people who knew how to do it. And it's sometimes it's kind of counterintuitive. Some of you guys came for that kind of like event that we had a few months back on a Friday, and we were doing like the laparoscopic stuff, and you guys were reaching in with the graspers and pulling out that little folded up piece of paper and getting like a little prize. They have to learn how to be able to look at the screen and move their hands and get those instruments to do what they want them to do. And sometimes that takes, a lot of practice and things like that, because it's kind of reversed. Right? You have to think about it in terms of flying a plane, that if you move your hand down, the tip of your instrument moves up. And vice versa, you move your hand up and your tip of your instrument goes down. And if you go to the left, the actual tip of your instrument is going to move right. So those are things you have to think about and become proficient at doing without having to really think about it. You can have an error in the vision system somewhere. The monitor goes out, the light source goes out, the camera box goes out, right? Your other equipment fails, right? You had your CO2, your insufflation machine is running off of tanks that are in the back of the tower. Well, we forgot to check to see if those tanks had enough pressure or enough gas left in them to last an entire surgery. Now we're in the middle of the surgery, and all of a sudden what we see is that the abdomen just starts to collapse. And now we can't see anything anymore. And we've got this camera and scope in there that's got a light source attached to it, and it's on. And now there's tissue touching that light. we could potentially burn the patient. Right. One of the other things to remember is now, if we open the patient up, we're dealing in everything in 3 dimension, right? We can see it, we can touch it, we can feel it, and we can look all around it and stuff like that. When you're looking at it on a television screen, it's all two dimensional, and that also comes into play with how far in or out do you need to have those instruments, right? And you're like, okay, and you look at the screen, you're like, okay, that's right there, and you're going to reach for it and grab it, and not realizing that it's further back than what you're seeing on the screen. And not everyone, can do it. Some people get a little bit of motion sickness because that camera is moving all over the place and swinging around and stuff like that, and you're like, oh, just staring at the screen, watching it move all around. It starts to mess with your equilibrium and stuff a little bit. But all right, does anybody have any questions over any of this yet? Okay. This is where I'm going to pause. And on Friday, we'll pick back up right here on chapter 22. In the meantime, you said this. Yes, and so endoscopic surgery, it can go through natural. So like the endoscopy department is putting it through like natural openings. But in the OR, we can also do the same thing. So if we're doing like, if we're looking at the vocal cords, we're just going to go through the mouth with special instrumentation that's minimally invasive like that. Urology, if we're doing cystoscopies, we're using the rigid cannulas and stuff to go in there through the natural opening of the urethra. But yeah. Groups B and C, I'll see you guys tomorrow in the lab. Group A, we'll see you Friday for lecture, and then we'll see, everyone who can come. Yes, if you're going to do a laparoscope, you have to make an incision because you need to put the cannula in. We don't have any like natural openings in the abdomen. But then if you can come on Friday, we'll be doing more practicing of gowning and gloving and scrubbing. And then we can even practice gowning and gloving each other. You guys enjoy the rest of your night, and we will see you guys later.